So once again, hello. My name is Jasper Zuputlitz. I'm the president of Bosch Healthcare. Today I'm honored to introduce three exceptional people representing three unique telehealth programs from across the country. Their telehealth stories range from the vast expanses of Alaska to a pioneer Medicaid program in the state of Wyoming, and further south to the University of Louisville, where remote patient monitoring is helping patients manage treatment of head and neck cancer patients. While telehealth, when strategically deployed, provides an opportunity to improve financial outcomes for healthcare organizations, create efficiencies for providers, improve outcomes for patients, and most important, lessen the burden of care for chronically ill patients by connecting them to their caregivers. The three presentations we are going to be seeing today will offer insight to how telehealth is improving these outcomes by empowering and connecting patients to their care providers across the care continuum, from post-acute care to chronic disease management and throughout palliative care. Please allow me to introduce, on the very right-hand side, Sam Johnson, the Executive Director of the Alaska Federal Healthcare Partnership, Cindy Keeney, a clinical research nurse from the University of Louisville, and Dr. James Bush, the Medicaid medical officer of the state of Wyoming. Sam, Cindy, James, thanks for coming. Thanks for traveling here and to speak about your programs. Without any further ado, I would like to hand over to you, James, and start the presentation. And I will hand over my microphone here. Here we are. Thank you.
Okay. Great. Well, thank you, Jasper, for that very kind introduction, and thank you all for sharing your lunchtime with us. I was very honored to be asked to speak about our efforts to promote telehealth in the state of Wyoming. And having been a provider in private practice for 25 years, I find it is far better to develop policies than to live under policies. So it seems self-evident, but for those who don't know much about Wyoming, except for maybe Jackson, Wyoming is the 9th largest state. We are certainly dwarfed by our good friend Alaska, but we are one of the two frontier states. There are two frontier states left in the United States, and Alaska and Wyoming are those, and that is based upon the population. So we have the lowest population, they have the largest area, but both of our densities are very low. As you see, over 10% of our state's population is covered by Wyoming Medicaid, making us and Medicare the two largest health insurers in the country. And large areas of the state are certainly impassable during wintertime. If you just look at it on a map, you'll see two towns that don't look too far apart. However, you have a mountain range in between. And Wyoming is one of those states where we just often say, we cannot come to any meeting because, of course, the blizzards. Very many of our sickest are located over 3 hours from providers, and when I was in private practice in Fort Collins, Colorado, I had patients who drove 3 hours each way from Wyoming for their primary care. We only have 2,000 physicians who carry a Wyoming state medical license, but only 1,000 actually practice within the state. We have only 26 psychiatrists for all 544,270 people. Of those 26, 6 of them are child psychiatrists. So the entire state is a mental health professional shortage area. Outside of the town of Jackson, Casper, and Cheyenne, the rest of the state is a health professional shortage area. So we have major infrastructure troubles as to how do you provide care to these people in rural areas when we don't even have adequate providers, and every provider who is there is very busy. And for any physicians who are out there, Medicaid pays higher than Medicare in the state of Wyoming, and we encourage people to move to our beautiful state to help. You will have all the patients you would like. So the telehealth consortium is one of the things that we knew we could do. We went to the legislature. We asked for a legislative authority to create a consortium. We included the Office of the Chief Information Officer, state agencies, and we wanted to partner with our private health organizations to develop a statewide interoperable system using existing infrastructure, and that was very important to us. We changed our Medicaid policy so that we would pay for telehealth, because if you don't pay for something, no one's going to provide it. We went to our other insurers, Blue Cross, Cigna, and others, who were not paying for telehealth, and asked them to please adopt the same infrastructure. And they did. We went to our state board of medicine and we changed our licensing. So Wyoming went from a very difficult state to get a license, and we actually had to come in person for an in-person interview for a license. We now have one of the most advanced medical licensing. We made arrangements so that specialists who only see 12 cases in Wyoming a year do not need to get a Wyoming license. They just need to have a Wyoming physician make the consult. And this is all very important stuff. In terms of the development of our telestroke, tele-MI, teletrauma, we had to wait for CMS to come out with the new telecredentialing rules for hospitals. We then took templates from that, and we have made them available to all of our hospitals, so we have the same templates for telehealth credentialing. So that's just a typical nice Wyoming scene. So when we started doing this, when we started building the system about 4 years ago, the easy thing to do was we helped with grants. We put these systems into our hospitals. We started providing continuing medical education, staff training, patient education. They can go to www.wyomingtelehealth.org, and they can see these schedules online. Currently in the state of Wyoming, I'm pleased to say we are now, Medicaid's on track to pay for about 2,000 telehealth visits a year. Our prison health services are doing this. We now have hospital-to-hospital consults. We are starting to put them into nursing homes now, since CMS has given the okay for nursing homes to be originating sites. We have one provider who in Saratoga, Wyoming, a beautiful little spot where you can fish off of Main Street. He is now, in one day, he would do a geropsych consult from a nursing home patient to psychiatrist in Evanston, about a 4-hour drive. He could then turn around and take another patient to a wound care consult in Cheyenne, both of those preventing transfers. And we have a patient, a very ill patient up in Sheridan, who's going to need a total bowel intestinal transplant, who's now seeing the transplant team in Stanford, in Palo Alto, I think, California, and they are now doing their monthly follow-up visits via telehealth. Whereas before, Medicaid was having to pay $2,000 a month to transport mother and daughter to California for her follow-up visits. So it is already being very widely used in many areas. But we also not only want to empower our physicians and providers, we want to try to help work with the readmission rates. And so we want to reach out to our patients and try to engage them more in their health care. And so one of the areas we are working with is in Bosch. And so we already had a health buddy system that was in place, but we didn't have a really good infrastructure. And so while we do like the health buddy system, the easy 4-button technology, and it all sounds very good on the East Coast, but I'll show you some of our troubles we had with it in Wyoming and how we're overcoming them. So, but we are very interested in the health buddy system, and we are taking steps, and we set up a study to try to document to the legislature how this is working in Wyoming. Those who were at the earlier conference where they had the pros and cons, and I asked a question about how do you take a limited study in a defined population in a confined area and transplant it to a population, and to gather data that you can then use in the real world. Our goals of the Healthy Together is our case management project, and we're partnering with Bosch in the telehealth project. And our goals are very simple, and it's everyone's goals. We're trying to decrease our costs, decrease our readmission rates, while increasing our ability to reach patients prior to crisis, enhance the numbers of providers using evidence-based guidelines, improve HEDIS indicators, and improve the quality of life for our citizens. Seems very simple. We had challenges. Medicaid population does indeed have a lower literacy rate. We have to put everything in 4th grade level of writing. This is a very mobile population, so they tend to move all around the state and at a moment's notice. And sometimes you have to go to the nurses in the community and they say, "Where's Mary Jane?" She says, "Oh, she's sleeping over at her aunt's sofa." Now, these are real stories. There is a higher incidence of mental health and substance abuse in this population, and those are the patients who are actually driving a large part of our healthcare costs. And believe it or not, a lot of people, when you say, "I'm from the government and here to help you," they don't always believe you. And they are sometimes they're a little selective in who they want to share information with. A big part of Wyoming is the connectivity. And a lot of these people don't have land telephone lines, and those who have cell phones, they're again not always willing to share them with you. A big part was in the program itself. Earlier, it was sort of a free form. We had our healthcare case management provider was just sort of passing out health buddies to people who sort of wanted them and seemed engaged. We only had about 27. We budgeted for over 100, and they really weren't following a strict protocol. And I said, I cannot demonstrate to the legislature and to the governor the cost efficiency of this. So I want to expand this program because I believe in this, but we need hard data, and we want to get the best results. And the best results is following current protocols. We had already had a budget system. State cycles tend to move in long years, and trying to reallocate dollars, which had already been budgeted up to 5 years earlier, is sometimes challenging. And trying to keep things within a program study design. These are some of the real-world obstacles we came across. However, we are able to enroll more females than males. We had a pretty good age distribution. We focused in, we pulled where cases are costing the state of Wyoming the most money. And you can see we had coronary artery disease, diabetes, hypertension, comorbidities, COPD, diabetes, heart failure, and hypertension and diabetes are the sorts of patients that we're involved with. And every study shows that these are the sort of populations where you're looking at. Compliance, again, this reflects some of the obstacles we talked about earlier, where you have some patients who are certainly non-compliant, up to a good number who are very compliant. And as we track these things, we could see that sometimes we had patients who would be enrolled, but then they wouldn't connect the system. Sometimes it was as simple as it was an older infirm patient and they couldn't move the furniture to plug the equipment in. And who could go out and help them plug in the equipment? And so you have to track these things to improve compliance. And the blue line is showing the compliant patients, and I'm pleased to say that at least is going up. It's not yet where we want it, but at least the numbers are starting to move in the correct direction. So some of the things that we learned from this is you got to budget enough. For example, we didn't budget initially for cell modems. So that was an extra cost because all those patients who didn't have landlines. And now, but there is the technology with Bosch that you can put a cell modem into these patients. But you had to think about that at the beginning, and none of us had thought about that as a problem. Adequate staffing for enrollment and management of patients. You have to be able to dedicate enough resources to manage a program like this and a study like this, and you just can't have one person sort of doing this in her spare time. You have to ensure that data mining will follow your selection criteria. And another thing we're very proud of is we have developed what we call our total health record. And basically the state of Wyoming has committed the resources where Medicaid bought and developed an HIE that's statewide, and we have an electronic health record that we are making available to all of our providers with a personal health portal at no cost. No cost to the patient, no cost to the provider. This will meet meaningful use standards. What we are planning on doing to totally integrate this is we want to take the Health Buddy data and integrate it into the personal health record and to the total health record so that the doctors and the patients at their computers will be able to access this data without having to go logging on to other systems. is that total integration is where we're going, and that's our vision. We're not quite there yet. This study is to help give us the data to demonstrate the need for that. So that's a very quick overview. Thank you.
Thank you very much. So I move right to the next presentation and take questions then after we have the three presentations. Cindy?
Can you all hear me? What do I do? Show me. You want to show me? Sorry. Well, I'll go ahead and get started. I am at the University of Louisville. I am part of an interdisciplinary research team. I'm the nurse part of that research team. There's only 5 of us, and we're housed within the School of Medicine, and our focus is pain and symptom management and palliative care, and not necessarily palliative care at the end of life. We are always trying to get palliative care initiated at the time of diagnosis. We ended up doing oncology because we have the James Graham Brown Cancer Center right there, and then we got involved with the VA system because our physicians who also are at the James Graham Brown Center also do double duty at the VA hospital. So that's how we got involved with VA. We had been at a meeting and were challenged by a group of clinicians who told us, you can do what you want. You need to be looking at this head and neck cancer populations because nobody can do anything with them. They were talking about their pain. The symptom burden was so great in this population. They were missing appointments. A lot of them were quitting, were stopping their treatment early on because they just couldn't handle the symptoms associated with it. So that was what we were challenged. And when we went and looked at the data, the evidence base that was out there, there wasn't a whole lot, but we were impressed with Dr. Vandenbrink's work out of the Netherlands, where he had reported positive outcomes with using telehealth and symptom control algorithms to a head and neck population there. So that's why we came up with the idea to do that. We thought we would build on that. So with that in mind, our research team tested the impact of this interactive supportive telehealth intervention on device usage. Doesn't matter how good you are if they don't use it. You have to be able to test that. And also the quality of life symptom burden, patients' overall satisfaction, and self-efficacy was also identified to see if they would be better able to manage their own symptoms. We did a randomized controlled trial. We enrolled 80 patients with newly diagnosed head and neck cancer. The treatment arms were, they could have had surgery, chemotherapy, or radiation, or any combination of the 3. The intervention itself involved the development of these symptom control algorithms, and we did that through using participatory action research methods. We surveyed the current and past patients. We surveyed clinicians to find out exactly what symptoms were the most difficult to manage, what were the symptoms that interrupted your quality of life the most, what gives you problems now that you've completed treatment, what did we do well, what didn't we provide. We also, looking at the evidence base, then we took all of that information and created these very interactive algorithms. We chose the Health Buddy as the appliance to deliver these interventions to the patient, and we reviewed so many different monitoring systems, but it was the only one that we found that was able to deliver a large amount of text to the patient in their home. And plus it was very simple, extremely simple, easy to use. So that was the beauty of that. Then from a monitoring standpoint, the way we could actually program in flags. For example, in this population, it has a fairly high, comparatively speaking to other cancers, a fairly high suicide rate. So anything that would trigger that the patient was suicidal, homicidal, any of that stuff would have immediately brought a red flag up on my computer. So it made it very easy to prioritize your treatment to them. What we found with these patients, well, one other thing, we had, with the usual care group, they completed 3 sets of surveys that were just like the Memorial Symptom Assessment Scale. the FACT scale, and then we had a self-efficacy scale and patient satisfaction. So they did those at 3 data points in both groups, and then the intervention group answered these questions every day. They would log on to their Health Buddy, and they would respond to questions, and based on what they were, how they answered the questions, the device would give them information. It would either educate them, it would either reinforce their current behaviors, or in some situations would tell them to contact 911 or go to the nearest emergency room or call their treatment team, whatever we had told it to do based on the symptom. So when at the end of the study, we found that it was extremely well utilized. We had 86.3% of patients utilize this device we had a modal percentage of 100%, so it was pretty much across the board used quite a bit. Everyone found it was extremely easy to use. There were no refusals at the consent time over fear over the technical issues. We had tried to do something at one other time using an internet-based service, and that was a big draw. Some of the patients didn't want, some of them liked that aspect, but for the most part, they just felt like they didn't have time to do that, or they thought it was going to be too complicated. This they didn't think that. During the study, we only had 2 patients develop problems that we had to go out and make home visits, and they had just gotten it unplugged. So other than that, we had no problems with that. We found that patients loved it, absolutely. They felt that their treatment they felt they got better care as a result of having it. Most of them said that it provided comfort to them to know that a nurse was watching their responses every day. So they saw that as definitely an added benefit. And also helped to navigate the system. They knew who to call for what. In a system where they have so many different specialists, that is just very important for patients. As regards to symptom burden with the Memorial Symptom Assessment Scale, as you can see in the red there, the control group pretty much they ended at a much higher symptom burden than what they started with, and this is. We only followed them a few weeks past post-treatment. In the research, it even shows with head and neck cancer that oftentimes their symptom burden will continue to deteriorate even long after they've stopped treatment. In our intervention group, we almost brought them back to baseline, which was pretty phenomenal, and it was significant. With the FACT scores, we found the quality of life certainly they did report a higher quality of life as a result of undergoing the intervention. And again, we brought them almost back to baseline. And part of the reason is just looking at with the FACT, I don't know if you're familiar with the FACT scale, it has several sub-scores, and one of them being physical well-being. But looking at the physical well-being, we saw the most significance there in that physically, they felt that they had an easier way to go physically and functionally with the intervention. And again, this is a trial outcome index. Many feel that that's a much greater indicator of quality of life because it is a combination of the physical and functional well-being subscores and also the specific concern scale that's associated with head and neck cancer. We did the self-efficacy scale that was used in the Netherlands. It had been translated, actually had been validated in the U.S. However, our patients, there wasn't a difference. They said that they didn't make more calls as a result of having the Health Buddy, even when it told them to have that intervention. However, they all indicated that, or most of them indicated they had a greater ability to manage their condition with the device. And that in and of itself is that not a reflection of self-efficacy? So having that, we just think that we probably, we're now rolling this out to a lung cancer population, and we've altered that a little bit to collect that. We are now looking at different cancers. We're looking at we have a grant out to roll this out to caregivers of hospice patients with our local hospice organization. We are looking into survivorship. Now that we get them through the treatment, so many of our patients have a hard time with survivorship long after treatment is ended. So we're looking at that. We have had interest in rolling out the head and neck cancer trial into a multi-site trial, and we're now exploring that with a couple of different organizations in the state to maybe do an R01. This is Myrtle. While James has the problem with this vast all this vast or property that they have to go through in the weather. This was Myrtle jumped on my car. I met her about a month ago when I was delivering a Health Buddy. Pulling it out of the back of the car, I heard a crash, and you could not get her off my car. And they tried, and finally they had to lock her up, and she was not happy about it. That's it.
Thank you.
Hope you don't get pictures of this.
Really impressive results. So, Tim? Okay.
Well, I've been given the dubious honor of leading you in the calisthenics after lunch. So if you gentlemen and ladies in the front, there's a couple chairs up here, so if you'd like to come forward. Good afternoon, and thank you for the opportunity. I'm from the Alaska Federal Healthcare Partnership, and we've developed a partnership with Bosch, the Turtle T400, and we combine that with a 24/7 call center that's provided by Critical Signals Technology to enhance healthcare for chronic disease patients in the state of Alaska, improve their quality of life, keep them out of the hospital, and I hope this short video will help you understand what we're doing. If I can see it.
Yep.
Here we go.
It's going.
Alaska has been my home all my life. I was born and raised here. My mom was born and raised here. I can't see ever living any place else. It's the place to be. Fishing and hunting, and so to me, it's a way of life.
There's 280,000 federal patients in the state of Alaska. That's roughly 42% of the state's population. A very large number of those patients live in the bush where there is no road system. In some of these villages, when you're sick, the weather can be bad and you literally cannot get out. And you need some way to connect to the patient.
I had light stroke 6 years ago. I was down there mending nets in nice hot days. That's all I remember. I don't know how long I was out. I woke up under the truck and yeah, I was in terrible shape. I had 2 stiff heart attacks. They sent me saying they were making me come up there twice a year. They're going 480 miles round trip.
Healthcare in remote Alaska is very expensive. Traveling here is very expensive. The management of chronic disease, in my opinion, requires constant management, constant education, constant innovation of patients. So how do you provide health care to people as close to home as possible? The only way that we think we can do that is through technology.
Here at Atlanta, I have about 1,000 patients that I'm the primary caregiver for. Shirley is a type 2 diabetic with high blood pressure that I care for here at the clinic, and she is one of the patients that's using the Bosch Healthcare T400 at home.
At first I thought, I don't want to do this, and then I realized that it's so simple. I think it's a blessing. It's making you do the things you know you should do.
It gives us the ability to look at patients without bringing them to test. Now, I'm sure that there are a lot of people who wish they had that kind of technology.
Hello?
Good morning. Is Shirley available?
This is Shirley.
Oh, hi, ma'am. This is the telehealth station.
Just wanted to call and check in because we see your blood pressure came in a little elevated this morning. Are you feeling all right? I feel...
CST is a monitoring company that keeps people independent and safe in their homes, from personal emergency response systems to medication management systems and telehealth. We report red flags. Our role is look at what those vital signs are, and if there's a red flag or out of parameters, we're able to see those slight changes before they're so bad that they require a lot of healthcare dollars. We can have all of their vital signs in a date range from the last visit forward, sitting there ready for the doctor to look at.
So being able to access the data and see what their vital signs have been trending, I think it gives you a much more rounded picture of your patient's health, and that's very valuable. One of the main things we work on here at United is making sure that people are empowered in their care. And the one thing that the Bosch Healthcare T400 does is it allows the patient to be active in their own healthcare. If they're feeling sick, they have the ability at home to check their own blood pressure, check their pulse, check their oxygen. They are supported in a way at home that very few people are.
When you think about engagement in healthcare, that's where somebody's participating with you to keep you healthier. And it's really nice to be able to take care of people where they want to be.
You're empowering the patient to look after their own care, to help manage their own care. You're not only helping them live a better life, you're reducing the cost of the system.
I would absolutely recommend it to other providers. It's very easy. It's easy for the patient. It's easy for us.
I was in poor shape before, but since I got that machine, I take my vital signs every morning, so I keep my blood sugar down now. It allows me to do things I want to do. And I want to live long enough to see my grandkids grow up. It's amazing machine to me. Yeah. It's T400 that saved my life.
Good to see you.
Sorry.
Sorry. I don't know how you would explain Myrtle to your insurance adjuster.
How do I start from the current slide?
Yeah, that's no problem. One moment. Here's Myrtle again. Yeah. Let's do this here. Okay.
So I'm from the Alaska Federal Healthcare Partnership, and who are the members of the partnership? IHS, the Alaska Native Tribal Health Consortium, the Alaska Native Medical Center, the Department of Defense, both the Air Force and the Army, 2 Air Force, 1 Army, Department of Veterans Affairs, and IHS. Partnership's been around for 16 years. It's been recognized a few times nationally for the work it's done. Most recently, in 2011, the National World Health Association selected the home telehealth monitoring program as the best in the nation. These 8 federal health care providers provide health care to 285,000 federal beneficiaries, or roughly 40% of the state's population. That would make the federal providers the big payer in the state. Today, we're in 63 communities around the state with home telehealth monitoring, ranging from Minnesota's northern Canadian border to Atlanta, Georgia, to Albuquerque, New Mexico. In that green area in the center, which you can't see very well, but this area right here in the center, that's the only road system in the state. You can imagine that these people are not necessarily just rural, but they're also remote. What makes us unique? Well, the first thing that makes us unique is that we have a lifetime of care model. It's not an episodic care model, because I don't believe you can manage or improve chronic disease on an episodic basis, because you just can't do it. But right now, that's the most care model, the most prevalent care model, because of reimbursement and how it's structured. The other thing that makes us unique is this 24/7 call center, because patients don't get sick Monday through Friday, 9 to 5. Somebody's always there looking for the patient, looking out for them. Patients take a lot of reassurance in that there's somebody there to help them anytime during the day or night. I show you this because this is the patient that was very resistant to having her medications changed. But once she was on the home telehealth monitoring device, the provider could pull off her own data, talk to her about it, and she became much more compliant, easy to work with when the meds need to be changed. This is a native community, nearly 9,000 data points. And this is a very good diabetes program before we ever showed up. They reduced blood glucose by 27 points, A1Cs by 0.3. This is a military community. Only 5,000 data points here, but again, glucose is down, A1C is improved. So home telehealth monitoring, what are the clinical benefits to you? I like to use the words intelligent intervention. Gives you the ability to look at the patient in a timely, intelligent way to intervene as their health values begin to decline. That keeps the patient out of the hospital, out of the emergency room, off my $22,000 on an average cost medevac flight, allows you to increase the quality of life of the patient, improve their clinical outcomes, and save you money in the clinic or hospital. These are 3 patients, very sick patients. These are the information the year before they were on the home telehealth monitoring device and the year after. In 1 year, we saved $633,000. That's a lot of money. I'd like for you to look at patient 3 to the far right. That's Aggie that was out at St. George Island. Very sick patient, many chronic diseases. The year before the turtle, 5 medevacs. And the cost of a medevac from St. George is $35,000. In the hospital, 53 days. Do you think that's where he wanted to be? I know it wasn't because I got to know Aggie pretty well. He didn't want to be there. He wanted to be on St. George. And that's out where the Daily Sketch is filmed, in the middle of nowhere. Well, unfortunately, Aggie died here a couple months ago. And a condition identified by the call center, medevaced him to Anchorage. He got better because he wanted to do what? Go home. He went home. He died in 24 hours. That's the bad news. The great news is for 3.5 years, we kept this patient at home where he wanted to be, increasing his quality of life because this technology empowered him and empowered the system to take care of him. Now, while we did that for him, it saved us a boatload of money. And I'll go back. That clicked 2 slides on me. Thank you. This is a native clinic, 39 patients the year before, the year after. Clinical visits went down 69, or 29%. Saved them 31%. So if you could reduce your clinic visits of your chronically ill patients that are eating up your capacity, costing you a lot of money, increase their quality of life, improve their clinical outcomes, give you capacity that you can now generate revenue with, why would you not do that? This is a military facility. Again, everything's down. Year before, year after. Look at the savings, 31%. Seen that before? And one of the great challenges for home telehealth monitoring is how do you get the patient to take their vitals and send it in? I don't care if it's to a 24/7 call center or where. So I challenged my team to double what we call compliance before the end of December. They also have to have 300 turtles in the field by the end of December, which they're going to do. They beat that, and they got compliance doubled by the end of September. I think in large part because we said to the patients, if you send your data 25 times in any given month, I'll give you $50. They like to get paid for what they're doing. So compliance, it says 107%. It's actually over 110%. So what are the walkways? Home telehealth monitoring allows you to provide care as close to home as possible, in the home. It improves clinical outcomes. It improves quality of life. It reduces the pressure on the system, creates capacity for you, which equates to revenue, and it reduces costs for those chronically diseased, chronically ill patients. I just don't understand why we wouldn't do more of it. So in closing, I'd like to say that this is wonderful technology. In my view, it can revolutionize how we do healthcare in this country. In my view, it will never reach its full potential until we resolve the reimbursement issues. My hat's off to the ATA for all the work they've done, and to John specifically, and what they're doing in the future. And I would ask you to go home and talk to your legislators and your elected officials to fix this. Because if we, by not putting this technology in homes, we're costing you a lot of money, and we're having chronic disease patients end up with comorbidities that they do not have to end up with. Thank you very much.
Thanks very much, Sam. This has been really interesting. We have a few minutes for questions. Are there any questions from the audience? Please. Can you stand up, please, because it's difficult to hear otherwise.
Well, we heard monetary incentives help with people use devices. I was wondering from Professor Kinney how long your patients used, if you used any incentives, or did you see that need as well?
Well, for those in the usual care, they got $10 a survey, so they ended up with a $30 check. For those that went into the intervention group, they got $100 at the end. I was sharing it with the Bosch representatives earlier today. For our patients, that it just immediately creates an air of distrust. They don't like the incentive. I mean, they like the money, but there's this whole air of, why would you pay me for something if you believe it's going to help me, if it's part of my treatment? So there is that level that we have that. The other thing, as far as how long they were on it, some of them were on it for 4 months. And we had 100%. We had many that were on it for 4 months and longer, and every single day, they responded. So we did not have compliance issue problems. And this is incredible because in this group, this populations, they self-isolate even from their families because of communication problems, and there's body image disturbances, all of those issues. So that was just pretty incredible.
Wait, additional question?
I just have one question. Historically, a lot of the issues around scaling telehealth programs and implementations and around the model of scalability, ease of use in implementing programs, ease of setup. Can you talk a little bit about some of the more operational logistic components around the program, enrolling patients, or some of the issues you faced, or some of the challenges you've overcome around kitting products, identifying the right patients, figuring the right programs out?
Who's that directed to?
I guess even the presentation, any one of you chat about that.
Well, I'll try a first stab at it. And I think what you saw here is you have to look at everyone's population that you're looking at, and the challenges do vary tremendously between the Alaskan Native population, people within the Army, a Wyoming Medicaid population, a head and neck cancer group. I think we heard different challenges for each one of those groups, and the constant is you have to keep your team focused. And I think that this is something that we've learned is we have excellent technology that works when implemented correctly. And so as you go into a project like this, you have to have a very focused and well-trained team and keep your eye on the ball and be tracking things, because you don't know what your obstacles in your particular population is going to be, and you have to have flexibility to adjust to overcome whatever obstacle you arrive at. And so, I mean, we talked a little bit about the barriers I had to overcome, but I think if I was to go to a Medicare population, or when we expand into, we're working now with the integrated care system within Wyoming, so we're going to be dealing with private payers as well as our federal and state payers. We're going to have different problems. Do either of you want to add something, Sam?
Well, I was just, mine being research, choosing patients were just, anyone who was not incarcerated, an adult, and had new diagnosis of head and neck cancer. So it's fairly easy.
Challenges in Alaska, there are many. We refer to those as turtle hurdles.
Turtle hurdle. Yeah.
A couple things that we've learned painfully. We have a lot of cultural differences, and you cannot push technology on some of our particular cultures. It won't work. So we had to take a very soft sell approach and go to elders and allow them to talk to their family members and their children. And we're finally getting good traction, reaching the tipping point, and my team cannot keep up with the demand for the devices to go in the field. The other thing I did is I held back deploying more units, penetrating markets, 63 communities, because I needed to prove that we could use this technology around the state. And in some places in the state and villages, we're still on copper wire. So we have a lot of difficulty with communication. Sometimes we have to hit a satellite twice to get it back into the server in Anchorage. The other thing we've learned is that this technology, while it's wonderful, if you have a non-compliant patient, and that's at the root of picking the right patients, won't fix the poor patient. You show me a patient that will not take their blood sugar every day, I'll show you a poor patient. I live with a type 1 diabetic, a compulsive diabetic, but a poor diabetic patient you can't fix with this technology. The other thing we learned painfully is that the provider is the king. You can have the diabetes coordinator, you can have the dietitian, you can have the patient, you can have the clinical administrator, the hospital administrator, but if you don't have the provider, you've got nothing. So those are all some simple hurdles. Logistically, when you talk, I've got a team going to Nome next week or 2 weeks from now, which is up in the interior, and they're going to put turtles in 7 villages around Nome. And I once had a team go to Kotzebue, which is very close to Nome, and they sat for 5 days because the weather would never allow them to get out. So those are always challenges. And we talk about patients that are stranded in those villages along the coast of Alaska. In this time of the year in the spring when the fog is bad, you need some way to talk to that patient about what's going on with their health care. But we could talk for a very long time about Alaska. But for me to send a team to go fix one home, one communication problem, it's extremely expensive. Very, very expensive.
Question over here.
So I'm wondering, first of all, with some of these remote monitoring devices, especially for Wyoming and Alaska, how they're insulated against places where the electricity might be out for prolonged periods of time, and whether that's been a hurdle for you in terms of keeping constant communication with patients, if that leads to their non-compliance, if they can't use the device for some period, do they resume using it? I'm also curious what kinds of false positives your monitoring systems have encountered.
Well, the power system is better than you might think, and the communication system is better because of some of the projects we've done before. But we don't find, the biggest impediment that I see to them continue to use the device is fish camp. Fish camp. So they have to be out of their village in fish camp harvesting salmon or picking blueberries or harvesting moose or caribou. I had patients call me and say, I want to get that $50, but I'm going to fish camp. And I had to remind them, when you put your data in the turtle, it will be there for 30 days. So when you come back, just push the send button and we'll get it. But that's some of the biggest hurdles. Very rugged, they take it to fish camp. We have doctors that provide care in California and come back up to Fairbanks to provide care that carry that device with them. So there are a lot of good opportunities, but we've had great success.
Any more questions? So give our speakers a hand. Thanks very much.